I'm just going to get her chart opened here.
All right, so thanks everyone for tuning in. We're going to do another cold case conference today with some of our current UCH residents. So we've got Peter Hyson, one of our current third years, presenting a case which he had on wards currently. And then our three discussants today, Devang, Amin, Michelle Paek, and Jessica Koontz are going to be discussing this case for us. Thank you all for your participation in advance. So without further ado, Peter, go ahead and get us started with the chief complaint and HPI.
Cool. So my patient is a 71-year-old woman who came into clinic reporting a 3-week history of progressively worsening weakness, fatigue, as well as some lightheadedness. And she also had a kind of longer history, call it months, of kind of increasing weight gain. So the story is that she started feeling tired about 3 weeks ago. Symptoms sort of gradually got worse, fatigue got worse, and then eventually she actually had frank weakness and lightheadedness. She also noted that she had some dark colored stools recently, but nothing frankly bloody and nothing melanic. And she also notes a 20-pound weight gain in the last 3 months with worsening abdominal distension and lower extremity swelling. Otherwise, history notable for some recent medication changes. She had been on Lasix and spironolactone, but was recently switched to torsemide, as Lasix and spironolactone did not seem to be doing the job. And that's about it for HPI. Otherwise, on review systems, no fevers or chills, no cough, no dyspnea, no nausea, vomiting, no diarrhea. She also denied hematemesis or hemoptysis, denied hematochezia, no easy bruising or bleeding that she was able to tell me about.
Perfect. That's an awesome first piece of information. Peter, I think because you're hinting at a few things in this HPI, would you mind just go ahead and give us that past medical history as well?
Yeah, exactly. So the past medical history is most notable for cirrhosis, diagnosed around 7 years ago, thought secondary to alcohol, had been stable prior to this admission, although notably decompensated by varices found on EGD in past. No history of variceal bleed. She also has a history of breast cancer, which was status post-lumpectomy, distant past. Doesn't seem like she ever had chemo or anything like that. And otherwise, no big medical problems.
All right, very interesting. So I'll go ahead and throw this one to our discussants. Guys, take it away. What are you thinking after hearing this HPI and the past medical history?
Worried about anemia, possible GI bleeding with the fatigue, lightheadedness, possible dark colored stools, and then worsening decompensated cirrhosis with the weight gain and abdominal swelling.
Then with the melon, still thinking about some other causes of probably lower GI bleeding and slower diverticulosis or I don't know, internal hemorrhoids, IBD.
Great. Yeah, I think that's a great place to start. So I'm going to go ahead and actually switch over to the whiteboard right now, just so we can talk about some of these things in a little bit more detail. All right, so I think what you guys got at in that initial presentation is kind of how we think broadly about weakness and fatigue in our cirrhotic patients. And so let's just create real quick a kind of schema or differential for how we're breaking this down. And so Michelle mentioned anemia. And Devang, what else are you thinking when you hear weakness and fatigue in a cirrhotic?
The fluid overload could also just generally make their circulation much worse. And then Cassandra mentioned in the chat there, like SVP possibility, like if they are infected.
Yeah, I was definitely going to say infection broad, but SVP specifically.
Great. I think that's excellent. So really big categories, kind of similar to our other patients, but things that cirrhotics are more at risk for. So anemia, bleeding, whether that's GI or other, progression of their cirrhosis, which Michelle hinted at with the weight gain, the edema, and then infection broadly, SBP and others. Anything else you guys want to include on this list?
I would also include like hepatic encephalopathy. Sometimes that can present with weakness fatigue.
Great. Absolutely. And then Cassandra brings up another good point in the chat. So just like general nutritional stuff. Sometimes these people are a little bit more decompensated. They don't have access to food. They're still actively drinking alcohol. And so always keeping kind of our nutrition and kind of overall health status in mind. But I think this is a really, really excellent way to start thinking about it. And right, it helps us put our cirrhotic patients and their kind of general initial chief complaint into buckets and helps us work from there. All right, anything else you guys want to know from that initial first aliquot of information, the HPI and the chief complaint and past medical history?
How are other organs? Any hepatorenal stuff or heart working okay?
Yeah, so prior to admission, she had normal renal function, and she has no history of heart failure or coronary artery disease that we are aware of.
Great. So I think Devang brings up a good point. We're just thinking about other causes of volume overload. And so, right, we're trying to break this down into the heart, the liver, the kidneys. And I think that's a great place to start. So always being systematic about what we're working through. All right. Anything else, or do you guys want to get some more information about this person?
Exam and lab.
Perfect. All right. So I'm going to throw this one back to Corey. All right. So Peter, go ahead and take us through, if there's anything pertinent, her social history and medications real quick before we get into vitals.
Sure thing. Yeah. So social history, she's a never smoker. She does have a history of drinking in past, although it's a little bit difficult to quantify. You know, the chart review drinking history says 3 to 4 2-ounce vodka tonics per day, and had the diagnosis of alcohol use disorder in remission. She's a little bit squirrely about when her last drink was, but it sounds like last drink in April of this year. Otherwise, she, I already said, never smoker, lives with her husband. They have like a family business together. There's really no history or notable history of like sick contacts or travel, or anything like that. Family history notable, there's at least elevated LFTs running in her family, although it's not clear that she has relatives who have cirrhosis. And surgical history is not contributory. As far as meds, she takes some Xanax for anxiety, although it sounds like she takes it infrequently. Otherwise, she's on some vitamin supplements, calcium. She takes citalopram 10 milligrams daily. She takes omeprazole 20 daily, rifaximin 550 twice a day, torsemide 15 milligrams daily, and she takes zinc.
Discussants, any thoughts on the social history, medications, and family history?
Has she missed any doses of her medications in the past week or so?
No, she's been compliant with her meds, she says.
And Devang, talk me through your thought process there. What was that? Why did you ask about the medication compliance?
So in particular, like if she's missing doses of her torsemide, that could throw her off with the volume status, skipping the rifaximin, or I mean, honestly, rifaximin's super expensive, and if a patient can't afford that, that may just be inappropriate. If she's missing that, she could go into hepatic encephalopathy as well.
Excellent. Yeah.
And missing omeprazole risk of bleeding.
Yeah, wonderful. I think that's great. And I think you bring up a great point about the rifaximin, especially when we all rotate through Denver Health, keeping in mind that some of these medications that we prescribe to our patients for good reasons often aren't attainable once they leave the hospital for cost reasons. So excellent point. And then Michelle, I think I cut you off before you started saying something.
Oh, when I saw rifaximin on her med list, I then immediately thought that she must have a prior history of HE.
Great. Yeah. So when you see rifaximin on the med list or you see lactulose, always digging into that HE history to see when was it started, why were they on it, and if they're compliant. Really good. But otherwise, I think, in my opinion, the social history doesn't get us a whole lot closer to sort of figuring out why this woman is now coming in with 3 weeks of weakness, fatigue, lightheadedness. And I think our initial differential, the GI bleed, anemia, decompensated cirrhosis, I don't think we're necessarily closer to figuring that out just based on this social history. Would you guys agree?
Yes.
Cool. So in that case, let's go ahead and just get into the vitals in the exam, and let's see if we can start breaking this thing down a little bit.
Sure. So her vital signs were all stable. She was afebrile, heart rate in the 80s, breathing regular on room air, blood pressures like 120s over 60s. And then on physical exam, she's chronically ill appearing, I would say. She is jaundiced. She has icteric sclera. She did not have any jugular venous distension that I was able to appreciate. Her heart is regular rate and rhythm. She does have a systolic murmur, which she says has been auscultated in the past. On pulmonary exam, she's moving air well. I would say that she has faint bibasilar Ralls, but nothing else focal on exam there. Her abdomen is mildly distended, but it's not tense, it's soft. Hard to distinguish whether there's a fluid wave. It's not tender at all. And then lower extremities, 1 to 2 plus pitting edema, I would say. And she does not have asterixis that is notable. And she's alert and oriented ×4.
That is an excellent exam. Discussants, what do you guys think about this next set of information?
So I think this helps us rule some things out or make them less likely on our differential. So no asterixis in her orientation, I think, make HE less likely. Her benign abdominal exam, although it doesn't rule out, but makes me a little less worried about something like SVP.
Any focal neurologic deficits, or like is the weakness just generalizable or in any focal areas?
So I can't claim to have done a thorough neurological exam on her. I would say that it seemed like more of a diffuse weakness, and kind of in the course of the time that I took care of her, I did not appreciate any focal deficits.
And
This
Michelle,
exam also
Sorry,
makes me kind of broaden my differential a little bit. And just think about heart problems. Like, I know we're all locked in on the cirrhosis is the cause, but I don't know. Bibasilar crackles, like, could be cardiogenic too.
I think that's a great point, Devang. Keeping our differential open, we don't have any labs back yet, keeping it open based on kind of some of the more general things we're seeing. I think that's excellent. And then, Michelle, why did you ask specifically about global weakness versus perhaps something more focal?
Yeah, I mean, if she's complaining of weakness, you want to make sure that she doesn't have something focal to make you suspicious of a neurologic process going on.
Yeah, I think that's a really, really good point to hammer home, is that really differentiating whether it's a global weakness or something specific and focal, because like Michelle said, if we're thinking a stroke or a specific neurologic process, that really changes our differential. Excellent point. And then Jason in the chat here brought up a good question. Peter, any platypnia or orthodoxia?
So I'm just a simple country doctor. I was hoping that we could explain what those terms mean.
Yeah, perfect. So Platypnia, so basically orthodoxia is that, when you sit up, your oxygen concentration, I might be saying this backward actually. I think it's when you sit up, your oxygen concentration drops, and then when you lie flat, it gets better. And platypnia is sort of the opposite sensation of dyspnea. So dyspnea, when you're trying to lie flat, you're more short of breath. Platypnia, when you're sitting upright, you're more short of breath.
So thank you for the explanation. I can answer now. She was not ever short of breath and did not had minimal oxygen requirements at any given time that I took care of her.
Perfect. And I'll say that those questions are kind of buzzwords for like a hepatopulmonary syndrome, where you've got a pulmonary AVM, and when you sit upright, the gravity-dependent blood flow shunts more through your sort of dependent pulmonary AVMs, which causes you to desat when you're sitting upright. And then the gravity-dependent process gets better when you lay down flat. So that's what that's a buzzword for. Excellent. And so I think the other point I'd like to just clarify that Michelle brought up was, she said she was less concerned about SBP, but didn't want to completely rule it out. And I think that's a really important point, is there's really only one way to rule out SBP, and maybe we'll get to that in a little bit, but our exam itself is not perfect for saying no SBP. So I think that's just another really critical thing that we should all take away from this. And then Peter, one more question in the chat. Cassandra asked, any questions of sleep-wake reversal, any symptoms of sleep-wake reversal, or any signs or symptoms of withdrawal?
Yeah, those are great questions. With regard to the sleep-wake reversal, she's having trouble sleeping at night, but it's unclear that this is reversal per se as opposed to anxiety. But I would say that there may be some sleep-wake reversal, maybe some cognitive slowing, but not very prominently. And then as far as the withdrawal symptoms, again, she is anxious. However, this seems to be more a baseline situation. She is not tremulous. She does not have tongue fasciculations, and her vital signs are normal.
Perfect. All right, so I'm going to throw a difficult question to our discussants here. I think before we get into the labs and imaging and all other data, does one of you feel comfortable giving us your problem representation, which is going to sort of help guide the rest of our workup?
We have a 71-year-old woman with history of cirrhosis, presumably hepatic encephalopathy as well, that is presenting with subacute weakness fatigue that is concerning for decompensated cirrhosis. And that can be hepatic encephalopathy or fluid overload or something else.
Yeah, I think that's excellent. So let's go back to this whiteboard real quick, because Devang brings up a good point. He mentions the word decompensated cirrhosis, and I think we throw that word around a lot, but let's just be really specific about what we're talking about. So to our discussants, and people can feel free to throw it in the chat too, when is a person with cirrhosis decompensated?
Well, when they're hepatic encephalopathy would be an example of decompensation. If they're also like getting fluid overloaded, that would be one. If they're no longer able to generate as much of their coagulation factors, they're like albumin, that would be another decompensation. If their synthetic function goes down significantly.
And evidence of like portal venous hypertension with development of varices.
Like all of the bad outcomes that we think about when we think of cirrhosis.
Great. And then what one big category on that? You said the bad stuff, but what other one big category are we missing on here for when you're decompensated?
Bleeding.
Yeah, so bleeding. And specifically, what type of bleeding are we most concerned about?
Varices.
Yeah. And so I think this is right. We put this in all of our notes. We all have a template for putting this in, but I think just being very clear that this is the stuff we're concerned about when you're decompensated, and then sort of what we need to do to figure out why. And so based on Devang's excellent problem representation and the stuff we're talking about, what's our differential right now for this person?
For all of these things. Yeah, I think, you know, we certainly have suspicion for bleeding given the stool. I would say maybe less suspicion for volume overload given her belly's not as distended, but could be. I mean, she has fluid in her lungs. And then hepatic encephalopathy as well. I think those is probably that's probably my top one.
Great. Jess or Michelle, any other thoughts to add?
I would definitely add SBP to the differential because that could be the cause of her decompensation.
Right, so SBP, is it causing the hepatic encephalopathy, or is the SBP, right, causing something back over here? Excellent. And I think another point that we can talk about always with hepatic encephalopathy is what are the things that cause us to have hepatic encephalopathy? What are like the 3 big triggers?
Infection.
Missing meds, yeah, like Cassandra said.
And bleeding.
Yeah. So infection, missing meds, and GI bleeding are going to be the 3 big things that trigger our hepatic encephalopathy decompensations. And right, when you're looking at all of this stuff, it's all kind of one big continuous spectrum. Like one thing leads to another, which sets off another thing. And so it's really important just to have this sort of global view of our cirrhotic patients when they come in, which you guys are doing really well so far. All right. I am interested to see some labs. How about you guys?
Yeah.
Absolutely.
And I'll say Graham brings up one excellent point, which is clot. So specifically, portal vein thrombus is a absolutely excellent point. All right, so I'm going to send this back to Corey and Peter. Go ahead and give us some labs.
Sure thing. So let me see, I'm just scrolling back a little bit here. She's been here for a couple of days. Starting with her hemogram, her white count on presentation is 8.1. Her hemoglobin is 6.5, and at last check it was 13. Her platelets are 81, and at last check they were 125. Notably, the last time she had a hemogram checked was in April of 2018, in fact. Her chemistry, again, scrolling back a little bit. On presentation, her sodium is 125. It was 134 at last check, and that was in June of 2020. Her potassium is 3.4. Her CO2 is 20. Her creatinine is 1, and at last check, it was less than 1, like 0.6. It appears to be her baseline. Calcium is 8. And then going through LFTs, her total protein is 5.2. Her albumin is 2.2. Her T-Billy is 16.7. Last check, it was 9.7. AST and ALT are 62 and 31. And let's see, LDH is 375. Haptoglobin is less than 30, which is kind of the lowest limit of normal. That's the level of detection, rather. B12 is 1,155, which is elevated. Serum iron is 59, which is normal. Coags. 3.1 is her INR, and at last check it was 1.1. Her PTT is 31.4. At last check it was 20. We also checked a D-dimer, which is 5,330. Her fibrinogen is 83. And I think that's about it for labs at the moment. We checked a UA, which was dirty, but not particularly remarkable. drew blood cultures, checked in ethanol, which was negative. And should I go into imaging or should I pause?
Let's go ahead and pause after the labs, because I think that's a lot of really good labs.
Yes.
Those labs make me deeply uncomfortable. So I'm gonna do the chief thing and defer and let our discussants talk about what they think of these labs and kind of how that's swaying their decision making.
Yeah, she obviously looks like she's having decompensated cirrhosis with her hyponatremia, coagulopathy, and then also there's definitely concern for bleeding with her hemoglobin of 6.5.
And then her MELD score is like 34, so 65% chance of death in 90 days. Yeah, active bleeding. Does she have any schistocytes on smear, just like in case we're missing something?
Yeah, I'm happy you asked that. She actually does have schistocytes on her smear. It's one plus schistocytes. However, it's kind of overall kind of an abnormal smear. So there's also anisocytosis, Burr cells are 2+. There's also spherocytes. So just overall, the red blood cell morphology is abnormal.
Yeah, and I'd say that all makes me really nervous in the setting of her low hemoglobin and the coagulopathy that this could get worse quickly.
Yeah. And Michelle, you bring up a really good point, just, talking about her coagulopathy. Describe her coagulopathy a little bit more for me and sort of talk me through why you're saying this woman is coagulopathic, because you're absolutely correct.
She has an elevated INR above her baseline, as well as elevated PTT. She's got a low fibrinogen, low haptoglobin, and then having schistocytes also makes me concerned for like a lysis process, like potentially DIC going on in her.
That's great. So I actually think we should talk about this one more too. So I'm going to go back to the whiteboard here, because I think you bring up a really good point. So Michelle, so let's talk about coagulopathy and liver disease here. And of course, Devang and Jess can jump in. So coagulopathy and cirrhosis. So how do we send DIC labs all the time in the hospital. And when we send DIC labs, what do we send?
Fibrinogen, D-dimer, haptoglobin, LDH.
Smear.
Yeah, and a smear.
Great. And a smear. That's awesome. And so this is right. This is kind of our go-to DIC lab panel every single time. And just off the top of your head, Michelle, Devang, or Jess, how many of these things are either produced by the liver or directly related to our liver function?
I know haptoglobin's developed in the liver or made in the liver.
I think all.
Are they all?
Great. So the haptoglobin is produced in the liver. Fibrinogen is produced in the liver. LDH is released by cells, so that sort of doesn't really apply. D-dimer is something that's released kind of in general inflammatory states and doesn't really apply, but it's elevated in liver disease technically, and LDH can also be elevated in liver disease as well, which is kind of confusing, right? We've got our DIC labs, but we see so many patients with cirrhosis, and these labs aren't necessarily as helpful.
Yeah.
Do you guys have an approach then to how we sort of think about coagulopathy and cirrhosis?
So they're at risk of both clotting and bleeding. The INR gives us some indication of whether they're making their clotting factors, but you have to keep in mind it's not actually an indication of their blood-like coagulation quantity. Like they do have protein C and S downregulated there. So platelets and INR are big things we look at, but thromboelastogram is what you would do to really like figure out where there's a problem in the clotting coagulation pathway. And it's like factors 2, 7, 9, 10 that are going to be down, the vitamin K ones.
Yeah. I think it's like factor 8 that you can look at to see if someone who has liver disease, cirrhosis, if you're actually worried about DIC in them.
That is awesome. So do any of you guys know, and this is a tough question, but you're exactly right, why is factor VIII something that we can look at to help differentiate these two things?
I actually don't know.
In the liver, I don't know.
Yeah, so Cassandra brings it up here in the chat, but factor VIII is something that's produced by almost all of the endothelial cells in our body. Sorry, so factor VIII is produced by almost all the endothelial cells in our body, whereas the other things are produced specifically by the liver. And so if you check a factor VIII level, you can often help your differentiation process between DIC and the liver. Because if the liver is shot, your factor VIII level should still be normal because the endothelial cells are still producing it. Whereas if it's DIC, it's affecting the endothelial surfaces across our body, and your factor VIII level should be low. And so, right, factor VIII tends to be high in DIC, and it tends to be low in liver it tends to be low in DIC, and it tends to be high in liver processes. So this is something we don't typically send, but it's extremely helpful when we've got a decompensated cirrhotic patient with a coagulopathy, and we're concerned about a bleed. And then anything else you guys, I know Devang mentioned a TEG. We'll see if that was ordered, but yeah, I would encourage everyone in a cirrhotic patient who's bleeding, send a TEG. It gives us a more dynamic look at their clotting cascade. So Peter, what was this person? Did you guys send any additional labs? Did you send a factor VIII level?
Yeah, so we actually did send a factor VIII level, and it was 242, which is marked as elevated. So at the very least, not low. I also sent an ADAM TS13, which was 43, indicating that it is low. And then I don't think we sent a thromboelastogram. Yeah, that's like.
Did she have fluid in her abdomen to tap or no?
She did. It was not something we could do at bedside, but we were able to get a tap with IR.
Okay.
Great. And Peter, do you want to talk about the paracentesis results now, or do you want us to talk about ADAM TS13?
Well, I think apropos of what looks like maybe a hemolytic anemia, we could talk about the ADAM TS13, and then we can move on to the peritoneal fluid.
Excellent. So Peter, this is kind of a more complicated question, so I'll ask you this because you took care of the patient. Did the ADAM TS13 change your guys' clinical management or sort of change the way you guys were thinking about this case?
Honestly, it really didn't. So this is something that I added on like when I got in the morning and saw what the labs looked like. But I think to go back to, what we were looking for, which would have been TTP, she did not have really what I would call clinical evidence of TTP. If you think about like the signs and symptoms thereof, yes, she had anemia and thrombocytopenia, but she didn't have fever or neurologic abnormalities. And while there was renal impairment, it was not dramatic. And she did not have blood in her urine. So overall, my index of suspicion for TTP was pretty low.
Yeah, I think that's excellent. And I think the other thing I would bring up about the ADAM TS13, first of all, I think sending it was, when you pick up this patient in the morning, it's the right thing to do. It takes some time to come back, but I think sending is the right thing. But one of the things, and I actually didn't know this till recently, does anyone want to take kind of a guess at what ADAM TS13 levels do in our cirrhotic patients? Yeah, they're also low, like Cassandra brings up. So cirrhosis is one of those conditions that will cause you to have a low ADAM TS13. I'm not going to pretend to know the pathophys of that, but checking an ADAM TS13 in a cirrhotic patient without some of the other clinical evidence of TTP will probably not push our clinical reasoning process and our diagnostic process along substantially. But I think while you're still looking for information, it's the right thing to do. All right. Do our discussants have any other questions before we get into the paracentesis and the micro results?
Get the tap.
Great. And I'll say, just so we're all on the same page, for our discussants, are we calling this right now kind of cirrhosis with coagulopathy, or are we calling this DIC?
Cirrhosis with coagulopathy. Because
Great.
of the factor VIII level.
Awesome. So we're saying cirrhosis with coagulopathy, but again, we haven't figured out why she's weak. We haven't figured out perhaps why she's perhaps more coagulopathic than our baseline. All right, so I'm gonna go back
Peter,
to
did
Corey
you
here.
do a rectal exam?
Did I do a rectal exam?
Mhm.
So I myself didn't, but they had done one before I got in, and it was reportedly negative. Also talking to her, we asked her a dozen different ways about kind of evidence of GI bleeding. And she told us like no tarry black stools, no frankly bloody stools. Really, her stools have looked pretty normal to her. And she says that, she hasn't had any increased frequency of stooling either.
Awesome. Michelle, I think that's a wonderful point to bring up. So what Michelle was basically getting at there was, is this blood loss or this more acute anemia, is it a luminal cause or is it an extra luminal cause? And what Peter got at with all their questions was luminal causes obviously are our GI bleeds. So things that are going to bleed into the lumen of the GI tract, which we're going to see via our rectal exam, in the toilet bowl, asking those good history questions. And then for our discussants, what are some of the extra luminal causes of blood loss?
Like DIC, hematomas,
Yeah.
hemothorax, bleeding into the brain, RP bleed.
Yeah. So I think that's great. So like hemolysis, hematoma, or what I'm just going to call like a space bleed, so bleeding into a space that's not the GI tract. And then things like sequestration. So, right, is stuff just getting pulled out into the spleen or something like that. But I think we all do this kind of in our head without thinking about it each time we see a GI bleeder, but really assessing when you see them on exam, DRE, history, are you seeing melena, are you seeing hematemesis, just to really be sure which one of these pathways we're going down. And right now, if you guys were going to take a guess or sort of push this one way or the other, do you think we're dealing with a luminal source or an extra luminal source?
Looks pretty
I would
luminal.
still guess luminal, yeah.
So luminal. So perhaps we're dealing with a GI bleed.
Yeah, especially with her history of varices. I don't know. I mean, it doesn't seem like she's fixing when eating, so that's
Yeah.
good. But
Yeah.
And the dark stools.
I think that's really good reasoning. I think, and Cassandra is sort of saying the same thing, that in our GI bleeders, always assuming a luminal source of blood loss, because that's the thing we can intervene on immediately, is probably the right thing to do. All right, so I'm going to go back to Corey here. Peter, go ahead and give us the results of this paracentesis and any other labs or imaging you guys got.
Okay. So the paracentesis fluid, it was clear and yellow. There were 107 nucleated cells, less than 2,000 red blood cells. 13% of the nucleated cells were neutrophils, and then the albumin was less than 1.5. The glucose was 84. The total protein was less than 3. Total cells counted was 100. And then, should I pause there or go into imaging?
I'll defer to my discussants here. Do you guys want to pause after the paracentesis, or do you want more imaging results?
I think you can keep going.
Okay, I'll sally forth. So X-ray of the chest showed normal cardiomediastinal silhouette, small to moderate left pleural effusion, some adjacent left atelectasis, clear right lung. And then we also did an ultrasound with Doppler, which revealed very minimal ascites, normal size spleen, unremarkable gallbladder without cholelithiasis or sonographic Murphy's sign. Bile ducts were not dilated, and shrunken liver with cirrhotic appearing morphology, sequelae of portal hypertension. Oh, this says no ascites one place, and this says moderate volume ascites another place. Nice. Right hepatic lobe measures 9 centimeters, and they did see a ill-defined hypoechoic lesion in the left hepatic lobe. And then the Dopplers showed appropriate direction of flow, and they did not show evidence of a thrombus. And then we got a CT as well. Which I'm pulling up. And the CT shows cirrhotic liver morphology with sequelae of portal hypertension. It did show mild esophageal and gastric varices and portosystemic / splenorenal shunts. It said no focal observations, probably or definitely HCC. And they did comment on the ill-defined hypoechoic lesion with the subcat within this left side of the hepatic lobe, which they said looked like a cyst. And we got an echo too, if you want to hear about that.
Sure.
Yeah, always.
I thought there might be some excitement about the echo. Left ventricular is normal. Left ventricular function is normal. Right ventricular function is normal, and ventricle is also normal in size. They had trouble estimating RVSP because there wasn't enough TR. No evidence of AS. Overall, it's a normal TTE.
Really boring.
Really boring. Yeah, her EF is apparently 72.6%. Sorry, man.
All right, Peter, that is a wealth of information. To our discussants, how do the paracentesis studies and the imaging results change your thought process, push you one way or the other? What are you thinking?
Well, I think the paracentesis studies kind of rule out SVP for us at this point, so I think we can take that off the differential now.
Great. Yep, you see less than 250 PMNs. I think that's a great call.
Yeah. I mean, I still want to get her scoped for GI.
Yeah, I feel like the other imaging studies didn't tell us too much new. Kind of helps us not worry about the heart, as that was a question we had. But
yeah, I think that's a really good point, Michelle. There's a lot of imaging studies here, and they, on the surface, probably don't necessarily push us towards any specific differential or any specific disease process, with the exception of ruling out SBP. But I think one of the other important things here, when you look at all these imaging studies, is sort of what is missing. And what we're missing is not a really clear source in the lung, not a clear source in the liver, not a clear source in the abdomen or pelvis outside of her known cirrhosis, and a heart that's basically normal. And so sort of seeing what is missing and what our initial differential was for that initial decompensation, what is left?
I think the luminal bleed is definitely still on there. We still had some questions about HE.
Probably the two that I'm thinking about.
Yeah, so I think luminal bleed, HE, and then have we definitively said this woman does not have an infection, right? Because our cirrhotics are more prone to infection, not just from SBP, but from a lot of different things. What other sources of infection
Yeah, I don't think
could we still be missing out on?
that out.
I guess pneumonia with the focal left lung findings.
Oh, like urinary source or skin source possible. I don't know, is she having any dysuria or anything?
She's not having any dysuria, and we did a urinalysis, which was quite bland.
Cool. But yeah, I think.
And then I still don't hang my hat on it until those blood cultures are negative for a while.
Yeah, and Michelle, talk me through why you want to wait a little bit on those blood cultures.
Yeah, it's just that I think it just, especially in these patients that can have atypical presentations of infection or very vague symptoms, I just always wait because I think there's always still a possibility that they could have an infection that could show up as bacteremia.
I think that is
Yeah, when I was
crucial point. Go ahead, Michelle.
This is Michelle now. When I was on my 8th rotation, we'd have a lot of patients who would show up with kind of like subacute fatigue, feeling unlike themselves. And I forget which attending I was with. I think it might have been Juan Lessing. But he was mentioning how in a surprising number, like surprising percentage of these patients, they have this like occult bacteremia that doesn't have any like focal symptoms or focal findings that would make you necessarily think of an infection.
I think that's a phenomenal point. Dr. Lessing is very good at his job, but I think that's a great takeaway. Jess is a fourth-year Med-Peds resident who has been around for a while, and she brings up a wonderful point. Like, elderly patients and cirrhotic patients can hide infections and present in atypical ways. And we know that cirrhotic patients are more prone to infection. We know that they're more prone to not showing perhaps the most fulminant signs of infection. And so always keeping a bacteremia or bloodstream infection on your differential is really, really good. And I think both Michelle and Jess, you guys are right on point that we have not definitively said this person does not have an infection yet.
All right. If they're at the risk for you, like you can think about thrombophlebitis or something.
Excellent. Yeah, really, really good point, Devang. All right, Peter, we've got about 5 minutes left. Are we getting close to a diagnosis here? Are these guys on the right track?
Yeah, no, I think they are. I think that the one piece of information I would provide that I hadn't already is with regard to kind of the question of luminal bleed. So I mentioned that she has a history of varices diagnosed on screening EGD. The corollary to that is that she'd actually had another EGD like 3 weeks prior to admission, which actually showed that her varices had resolved, and all they found was portal hypertensive gastropathy on that scope. So in fact, like when we talked to her with her sort of vehemently denying any evidence of luminal bleed, and the fact that if she really dropped 7 points on her hemoglobin, we think that it would have been probably seen somewhere. We actually felt like we could exclude luminal bleed, so we didn't pursue scope during this admission.
Awesome. I think
that's interesting with the CT showing the varices.
Yeah, no, and I think one thing I found on hepatology is that I guess varices can be pretty hard to see on scope. So, it could be that they were just overreading the CT a little bit, or maybe the varices are still there and they just couldn't see them for one reason or another. But at any rate, the fact that they couldn't be seen does sort of imply that they're fairly low grade if they exist.
That's great, Peter. I think those are some really good teaching points there. So what's the utility of seeing varices on a CT when we've got a scope that's prior? And then I think really taking into account like a 7-point hemoglobin drop, if that is a varice, we should see something. So Peter, with 5 minutes left, how did you guys make the diagnosis in this case, and did any other information come back?
So I would say, in fact, the diagnosis we arrived at was a hemolytic anemia related to end-stage liver disease. And so actually, like all the information we needed to make that diagnosis is already here. Hematology was consulted and essentially told us, I guess, what we've discovered during this talk, which is that in late-stage liver disease, you can have a hemolytic anemia process that's essentially indistinguishable from DIC, bearing in mind that all of these tests that we do are kind of biased by the fact that cirrhosis lowers your levels of haptoglobin and all these other factors. So from my reading on up to date, I think this is called spur cell hemolytic anemia, and it's really kind of a symptom of likely terminal cirrhosis, and just kind of caused by the liver disease itself.
Wow, that's awesome.
And Peter, did she have the Koontz, or would a Koontz be helpful at all in thinking about this diagnosis?
Oh yeah, that's awesome. So I totally forgot to mention that. We did send a Koontz right away, and it was negative.
Okay.
And the other thing that I was told, she had a type-in screen when she came in, not surprisingly, which I gather that a type-in screen will also often tell you if there are antibodies of concern.
And Peter, did those blood cultures ever come back? just to round out our work?
So yeah, she had blood cultures drawn when she was admitted, of course, and those were negative. However, she subsequently had a clinical decompensation and had another set of blood cultures drawn, which did ultimately grow 1 out of 2 GNRs. So I think it's a little bit of an open question, like, did she come in with an infection that we missed? I'm actually inclined to think that she maybe developed it during her course, like possibly a secondary peritonitis.
Awesome.
Hmm.
Wow, that is a fantastic case. So just to finally sum this up, so Peter, it sounds like we're calling this perhaps a spur cell hemolytic anemia, essentially hemolytic anemia due to end-stage liver disease, which is indistinguishable lab-wise from a lot of our DIC labs.
That's right. Yeah, that's what I would call it.
Perfect. And Peter, what was, if you could take away a couple like teaching points from this case or sort of things you'll use going forward, what was sort of your most prominent teaching takeaways?
Well, mostly I liked that this case forced me to go through my differential for hemolytic anemia. And I, got to think about TTP and HUS as well as DIC. And it was also educational for me, to what a degree all of the lab tests are abnormal in the context of cirrhosis. I was pretty scared that this patient had DIC when they came in, and my attending just kind of shrugged when she saw the labs and said it's just cirrhosis, and that pretty much turned out to be true. But yeah, I think also always being suspicious of lurking infection in these patients. Because even if you don't find it right away, they still might have it, and even if they don't have it when they come in, they might have it 2 days later. So, kind of thinking of cirrhotics as immunocompromised, I think, is reasonable.
Peter, that is a brilliant summary of this case. I love it. Do our discussants have anything else to add before we go ahead and end conference?
Oh, that's a cool case.
Yeah, it's great.
I was just wondering with that smear, like we saw the schistose and they said it wasn't a great smear. If they say that, like, if we see schistose, should we still like take that as literal like fact or what? I just don't know the interpretation.
Oh, I think the smear was okay. The thing about it that was interesting was the schistocytes were only 1+ on it.
Okay.
Unless you're seeing something that I don't know about. I'm told that like in frank DIC, you'd expect to see more than 1+ schistocytes.
Got it.
Yeah, I think that's a good point. Is I think a lot of times if you're looking at a smear and you're looking at a portion of it, you can sometimes overcall the number of schistocytes. So if you truly are concerned, that's when you need to get your hematology fellow in the lab to do a much deeper dive into the cause of hemolysis and see exactly how many schistocytes they're looking at. But great point, Devang. All right, guys, this was an awesome case. I had a blast. Thank you, our discussants. Thank you to Peter for putting a wonderful case together. The last thing we're going to ask you guys is if you wouldn't mind is just filling out this noon conference feedback survey. It's 3 or 4 questions, just to let us know whether you guys like this cold case format and whether this is something we should keep doing. We obviously enjoy it, but we'd like to get some feedback from you guys. So again, thanks so much to our participants and to our discussants. Awesome job.
Hey, thank you.